Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, October 21st, and it is time to do a live IC support group meeting. We do meetings online first and third Sunday of every month at 12:30, around and about Pacific Standard Time. We simulcast on Facebook and YouTube. So let's give it just a couple of minutes. Let some people come on into the meeting. Hello, Julia. It's very, very nice to see you. I see we got a couple of people over here on YouTube already. Hello, everybody on YouTube. Hello, Facebook. I hope that you guys are having a really good day. You know, the light's really weird here. So if I look purple, I don't know why. Even my lips look purple. It's very, very weird. I don't get it at all. So let me introduce myself again, Jill Osborne. Hello, Brenda. Hello, Kathy, president of the IC Network. My purpose in doing support group meetings is to give you so much information, so much knowledge, so much power that you can walk into any doctor's appointment and really advocate for yourself well. All righty. So we're going to do that first with some really good new information because I found an amazing new book that I'm going to recommend to you. And then we're going to take your questions and answers. Hello, Helen. Very, very nice to see you. Hi, Brenda. Nice to see you too. Hello, Marie. You guys, if you have questions about IC, please feel free to go ahead and ask them. Happy to do it. I hope you're having a really good Sunday. You know, unfortunately for me to make this work, I have to have most of the drapes closed. But outside here in California, I got to tell you, it's a gorgeous day, gorgeous fall day. The trees are orange and red. And oh my goodness, we're just loving the fall season. I know for some of you, it's already really, really cold. If you can on Facebook, if you could please just go ahead and post that we started this support group meeting, that would be amazing. I would very, very much appreciate it. Hi, Marie. You know what? I'm going to do that too. So I have to tell you, I read the most amazing book last night about IC and chronic pelvic pain, and we're going to talk about that. But let me do something here first. If you could just spread the word, that would be great. I'm going to spread the word right now on my Facebook page. Let's see here. Let's see, live IC group, support group meetings starting right now. All righty. Okay, all right. Okay. Sorry about that. It's a Sunday, and I got my flu shot yesterday, and my arm is really sore. Very, very weird. Okay, so I want to start this meeting. You know, every meeting now, I usually spend about 30 minutes talking about something new related to IC because I want to teach you more about how the body works and why pain happens and what causes the different types of pain that we're having. So generally for the first 20 or 30 minutes, we do a little bit of educational information. And then for the rest of the meeting, we're going to take your questions, okay? But here is the book that I think every single one of you guys need to go get. It's called When It Hurts Down There by Dr. Angie Storr. I want to make sure I pronounce her name right. Anyway, 15 proven techniques to alleviate pelvic pain. She is part of the Pelvic and Intimate Pain Center. She practices, she's an OBGYN, and she practices down in, I want to say Texas, I think. This is how I spent my Saturday night. It's a very small book. It's really only 70 pages. You can get through it literally in 90 minutes. What she talks about in this book is all the pelvic pain disorders that we associate with chronic pelvic pain and IC. She talks about bladder pain. She talks about IBS. She talks about endometriosis. She talks about pelvic floor dysfunction. She talks about vulvodynia. And for the first time, we really see this really lovely, simple, cohesive discussion that embraces all of these conditions to give you and I tips that we can use to manage our pain and understand our pain more clearly. And yes, you know, I mean, guys, seriously, we're doing the subtyping for IC, right? So we know, for example, that some patients have pelvic floor dysfunction. We know that they have injury. And let me just qualify this by saying, you know, we don't think of IC as a bladder disease anymore. We don't. We think of it more as a chronic pelvic pain syndrome. Okay, why? Because we know that organs outside and structures outside of the bladder are typically and usually involved. And so we're long past those days where we think of IC as an incurable bladder disease. We now think of it, again, really for most patients as injury or trauma as compared to a disease process. Although in some of the subtypes, like Hunter's lesions, there actually may be a disease process happening. But for the vast majority of us, instead, we really focus on the concept of injury or trauma. Okay? Mind-blowing, right? And especially if you were diagnosed 20 years ago, 25 years ago, or even 10 years ago, like I did. What did we always hear? This is an incurable disease. Well, we don't think that anymore. And in fact, with the subtyping system, we now, in fact, when Dr. Christopher Payne proposed his subtyping system, that was one of the points that he made, is that it's so unfair to label a patient with an incurable disease. And he makes the very valid, correct point that there are some subtypes which are curable. As an example, pelvic floor dysfunction. So if your IC began after a pelvic floor muscle trauma, pelvic floor injury, having a baby, falling, breaking your tailbone, all that sort of stuff, we know that muscles respond beautifully to physical therapy. And we can use the word cure in that context. Think also about, I mean, listen, seriously, if you've been online, you've gone to an IC support group, you've seen the diversity in the IC patient population. I mean, you know, for example, that there are patients who have bloody bladder walls. And then you've got other patients with completely normal bladder walls. Both of us diagnosed with IC, yet clearly we are not the same. We've got some patients with terrible pain, others with only frequency urgency. Both of us could be diagnosed with IC, yet clearly they are not the same. And of course, we certainly also know that a one treatment fits all approach does not work. The old theory that Elmeron was going to work for everybody failed terribly. Elmeron barely works better than placebo. Why doesn't it work? Because, hello, Elmeron works for people with bladder wall injury, but it might not work for people with pelvic floor injury. Okay? So, as we ponder chronic pelvic pain and as we ponder chronic bladder pain, we have to be receptive to the fact that there are multiple processes involved. And that's really one of the things that this book talks about. And guys, they don't pay me. They're not paying me to do this. Okay, you need to understand right now that it's really rare that I would ever let somebody pay me to sway my opinion. Rare. 25 years. Has it ever happened? I don't think it's ever happened. Man, I want to focus on quality. And the information in this book is so high quality, it's incredible. Okay, so she lays the foundation by talking about all the chronic pelvic pain syndromes, okay? And then she talks about what can we do to alleviate that pain. And she talks about some of the basics, right? So, you know, number one, we want to avoid foods that cause inflammation. And we're not just talking about bladder damage. We want to avoid those foods that we know promote inflammation in the body. Why? Because inflammation triggers more pain. It's really interesting. You know, have you ever had a cold or the flu? I mean, you don't just have a headache, a sinus headache. Your whole body feels miserable. That's because when the immune system is engaged, more pain is engaged. And so she talks about avoiding foods that are high in inflammation, like for some patients, gluten, or more importantly, refined carbs, fried food. You know, and I'm going to let you read this when you get it, because I really, really think you need to read it. She talks also about avoiding common irritants. So if you have bladder wall injury, of course, we know you would be a fool to be drinking coffee and soda and lemonade and cranberry juice and all that sort of stuff. And she also talks about the foods. If you struggle with vulvodynia, you might find reducing your oxalates important. Oxalates are a chemical it's found in many foods, but as it is metabolized, it can form oxalic crystals. But it's really known for triggering nerves and nerve pain in some patients. As an example, spinach is an example of a food high in oxalates. Berries, chocolate. Okay. She also talks about the diet with respect to endometriosis, which I'll let you read on your own. She talks about probiotics. And in here, she gives, and this is something that I've been meaning to do on the IC network, and we've talked a little bit about it. You know, we're all just now really trying to understand the human biome and beneficial bacteria and the good bacteria in your bowel and, hello, the good bacteria in your bladder. Urine is not sterile. We all thought urine was sterile 5 years ago, but with the advent of this new next generation testing, we now know that there's actually a lot of really good bacteria in the bladder. And of course, when you take antibiotics, you kill them. So as an example, there is a bacteria that produces the food that nourishes the cells lining the gut. And the human body does not make this food. It is made by this bacteria. And I've got an article on it on our website. But if you kill this bacteria, you kill the food supply. So what happens? Those cells die because they don't have the food that they need, right? Jerry on YouTube asked about anise. Anise should be IC friendly. It should definitely be IC friendly. I'd be surprised if it weren't. Most people could do anise real well. Okay. So one of the things she talks about in this book is she goes back to the basics with the research. And the question is what probiotic do you take? Well, yeah, there's a lot of lactobacillus out there. There's a lot of companies getting rich right now selling you probiotics. But if they don't have the right bacteria, is it going to help? And one of the things that I say to patients is don't just take the same probiotic. You got to mix it up. Mix it up with different probiotics. But she specifically talks about research that shows that lactobacilli, bifidobacteria, and streptococcus faecium are important to your biome. And she wants you to look for probiotics that have those three, if at all possible. And in the same time, she also says that, yes, and we know this, that there are some patients who flare when they have a probiotic, when they take a probiotic pill. And so what she says here is that the probiotics that are less irritating are the probiotics that come in yogurts, like a Greek yogurt or kefir. And yes, my friends, you can have yogurt when you have IC. I just don't want you to do lemon or chocolate or orange. Okay. I'm just checking comments here. And guys, be prepared. You can feel free to ask any questions that you want, but let me just get through this first. Of course, she says, you know, avoid unnecessary antibiotics. I mean, if you followed the IC network, you know, a couple of years ago, I wrote a ripping blog about why you should not self-medicate with antibiotics. IC is not infection. IC is injury. The problem is that the bladder only knows one language: frequency, urgency, pressure, pain. So you could have a bullet wound or a stab wound and it would feel like infection because those are the symptoms that we associate with infection. That is the only way that the bladder can tell you that there's a problem. And so you've got to really stop yourself from going to that leftover antibiotic prescription that I know most of you have in your bedside table and just pop in a couple. You can't do that. If you think you have infection, then of course you want to do an azo urine test strip. I mean, do an azo strip. And seriously, if you're double positive, nitrite, leukocyte, yeah, you have infection. Go leave a urine sample at your doctor, get it tested, and let's go from there. But if you do this and you only have positive leukocytes, you do not have infection. You probably don't have infection. You're probably having a flare. And that's when you don't reach for the antibiotics because you're going to kill the important good ones. And of course, she also says to start exercising because exercising actually helps your biome. Okay. So anyway, those were kind of the basics. But I want to talk about something else instead. I want to talk about her discussion about the brain and how pain is processed. Kim says, what if you only have protein? Oh, hon, you don't need to just have protein. Girl, you can have vegetables. You can have fruits. You can have corn-based products. There are lots of things you can have. I'm not telling you to not eat all carbs. I'm saying just lose the sugar, lose the sweet carbs, like the cinnamon roll I had last night for dinner, and I woke up all bloated. Hello, inflammation. Kim, what if I only have protein when I flare up? You don't need to do that, Kim. You don't need to do that. There are lots of vegetables that are IC friendly. You can find those on our website. And she has a really good diet rescue plan in here too that you can look at too. Okay. Okay, but hold on. So what excites me about this book is it talks about how pain is processed. And when you know how pain is processed, that's how you get to fight pain and control pain. So let's think about this for a moment. Let's say, well, in fact, I did it the other day. I cut my finger. I think you can see that, right? Okay. So when you injure your finger, what happens? The nerve from your finger goes up your arm to your spinal cord. And then it is delivered. It can start at the lower, it works its way up, right? It works its way up. And then at the upper spinal cord, it reaches the lower brain. Now, this is all split second, right? I mean, you know that if you touch something hot, you would go, ow. Okay. It's almost instantaneous, the way the body reacts to pain messages. But it is a testimony to the miracle of the human body, how that happens. No matter how smart we think we are as humans, the ultimate genius is just the way life is designed and our body is designed. Okay, so you hurt yourself. It goes up your arm or up your leg to your spinal cord. From your spinal cord, it goes here. It goes to your lower brain. Now, what's so interesting about the lower brain is that it controls something that I call gating, the spinal gate response. Because we have tens of thousands of pain nerves in our body, tens of thousands. And if those were all reaching our brain, we would be overwhelmed all the time. And so our body has an intrinsic way that it lets only the most important pain message through. So if you fell in, let's see, if you stepped on a nail, you know, your body would be consumed by that. You'd be jumping around and your brain is completely focused on that freaking nail. 2 days later, that's starting to heal. It aches a little bit, but it's starting to heal. Let's say you fall and you hurt your leg. Is your brain still paying attention to where the nail was, or is your brain focusing on your new injury? And the answer is it's focusing on the new injury instead. That's called spinal gate theory. And in fact, if you ever use a TENS unit, one of the ways that you can fight pain is you can mess with the gating response. So as an example, one of the things, gosh, you know, I even have, where is that book? I read this wonderful book called Pain, the Gift That Nobody Wants. And the author of the book, who is a doctor, went to leprosy clinics in India. And if you know what leprosy is, you know that it's a terrible bacterial disease that eats away at tissue. And so people with leper, it's highly contagious, and their fingers, their fingers get so infected that they become deformed and all that sort of stuff. And thankfully, with antibiotics, leprosy can be cured. But back in the old days, we didn't have that. So here he is walking into this leprosy clinic. And what he would see is that people would be doing this. They would be doing this. Or they would hit themselves on their leg See, I'm fat today. I'm sorry. I'm having a fat day. Okay. So they'd hit their leg. And when you hit your leg, you're fooling that gate mechanism. And so instead of that gate mechanism letting your bladder pain through, what it's doing is it's focusing on this new immediate thing. It doesn't know what it is. All it knows is it needs to pay attention to it. Doesn't know if it's good or bad. So one of the ways that you can interrupt the pain process is by interrupting the gating process. And so you should try that. I used to do that when I was flying with IC. And if you're driving with IC, if your bladder's starting to hurt you or your pelvic pain, just start slapping your leg, okay? So that's the low brain. The low brain is the brain that gates. But then it goes to the midbrain. Now, the midbrain is the one that establishes context. So, you know that when you're on a roller coaster and you're screaming, right? And it's fun. And you've got, you know, your heart is racing and your body is clearly under stress, although it is good stress, it's stress. But then, of course, let's say you could also be being chased by a bear, which is not fun. And you fall and skin your knee, and that's not fun. So how does your brain know the difference between something good or something bad? That happens in the midbrain because the midbrain establishes context. It establishes context. And what we know is that if a doctor tells you something's going to hurt, it's going to hurt. It's probably going to hurt a lot. If the doctor tells you, it's just a little poke, don't worry about it, no big deal, the odds are it's going to be no big deal for you because context matters. And so another way that you can fight pain is kind of by changing context. And I know that you've probably all heard the term cognitive behavioral therapy, which is, on the out sounds pretty offensive. It's like, how dare you tell me I need therapy? I have pain. Hello, my bladder's hurt. Don't tell me I need therapy. Help fix my freaking bladder, for God's sake. Okay. What cognitive behavioral therapy does is it messes with the midbrain. It messes with the midbrain. And if the midbrain is working a lot, if the midbrain is occupied, it cannot pay attention. It does not pay as much attention to that sharper pain. And, she does a really good job of explaining that in here. And so, as an example, one of the things that happens in the midbrain that I think is fascinating is something called learned fear. So for me, it's all about car rides and bladder pain. Because when my IC started, driving the car was agony. It was agony. I know some of you out there go through that exact same thing. And that lasted, I don't think I could sit in a car without crying for about 5 years because I had a really bad pelvic injury. Okay, but it's 25 years later. I can sit in a car now. I can sit in a freaking car and not be in pain. However, I have learned fear from that. And for many, many years, if somebody said, hey, Jill, you want to drive out to the coast? My answer was no, it's going to hurt. Even though it didn't hurt, hello, we're talking about learned fear. Learned fear. She also talks about, she says, when you're in pain for a long period of time, the actions in the midbrain start linking depression and anxiety with pain. And thus, if your depression and anxiety worsens, so does your pain. And again, as arrogant as we are as humans, as humankind, we still don't understand a lot about how stuff works. But we know is that the brain lights up. We can do MRIs of patients and pain patients and non-patients. And we see different parts of the brain lighting up in pain and versus and not in pain. That's because the brain is a network. It will grab a little bit from here and a little bit from here and a little bit from here. And that's really what makes you who you are. It makes us who we are. And so she argues very, very successfully in here that the more anxious and depressed you are, the higher your pain intensity. Thus, if we work on the anxiety and depression, if we reduce that, then this brain is not going to pass pain messages along. So, you know, that's why with IC subtype 5 central sensitization, one of the very first treatment priorities is, hello, let's work on anxiety and depression, because that's just going to make your nervous system more sensitive. Okay. And then, of course, the last place it goes. So remember, the pain nerve goes up your spinal cord to your lower brain, to your midbrain, and then to your upper brain. And it is your upper brain which then establishes where the pain is. And it tells you what to do about it. And the upper brain also kind of anticipates how intense it is. And so that's the part that sends the nerve signal back down to your finger and says, move that freaking hand away from the fire. Okay. So pain isn't just, I mean, pain sensation is so much bigger than we realize it is. It involves so many different processes. So the question is, if we interrupt those processes, we can reduce our pain level. And this is where this book really shines, is because it talks about what you can do, and it does it in a non-offensive way, because nobody here is telling you IC is all in your head. It's not. However, pain processing can be modulated in your brain to a certain degree, and your ability to address that is really going to help you. So I love this. So what the first thing she said, so how do we alleviate pain by targeting brain processing? Number one, use foul language when the pain is really intense. This kind of vocalization starts in the lower brain gateways. It's a spontaneous reaction to pain, and it actually reduces the pain signal. So you have my permission to curse. And of course they say, she's saying, we don't want you to curse every day, but this only works well when you're not accustomed to using foul language regularly, which last couple of years, my foul language is a little high. Okay. Anyway, and if you just don't, if that's not you, then skip that. But letting it out quickly is good. It's good. The second thing that she mentions is meditation. Okay. Why? Because when you control your breathing, and when you empty your mind of your stress, your daily stress, and when you breathe regularly and normally, and you're getting good oxygen, you're reducing the pain complex. And that's what we want to try to do, right? So we want to calm the lower brain, the midbrain, and the upper brain. And that's what meditation can do. Number 3, deep breathing. Well, duh. Number 4, okay, be happy. Now again, that's like totally offensive on the surface, right? It's like, how dare you tell me to be happy when my bladder is freaking screaming? How dare you say that to me? But what she's arguing in here is that if we combat the midbrain and we occupy the midbrain with happy stuff, it's going to be much harder for it to focus on the sad stuff and amplify the pain. I hope that makes sense. And I mean, that's like one thing that I have to say I've gotten really good at is the power of positive thinking, and it was only because my IC was so bad when it first started that I was just despondent and desperate. And somebody gave me, we had a book on Tape Store, and I found the lady there recommended that I listen to this Power of Positive Thinking thing. And it changed my life because I went from thinking sad thoughts every day to thinking happy thoughts every day. And it was interesting. I was listening to somebody else on Sirius, and they were talking about that. It's like we all have different channels, right? So we can live in the I'm sick, I'm in pain, I'm depressed, I'm frustrated, I'm angry channel. Or we can listen to the my family loves me channel, here's my dream channel, here is my nature channel, here is my pet channel. And they were talking very specifically about changing the channel. Don't live in the negative side, live in the positive side. Why? Because it helps the midbrain process pain less. Okay. And they talk specifically about doing yoga and Pilates, because when you're doing an exercise that requires concentration, you're making the midbrain work and you're distracting it from the pain. And so yoga and Pilates has been demonstrated in research studies to reduce chronic pain. And then another thing she talks about is interval training. I used to do a lot of interval training. I'm not doing it, but she says interval training works with a different part of the brain. Interval training is when you do something at peak intensity for a short time, then slow down, then go fast again. This fiddles with your body's reaction to stuff like heart rate and blood pressure, which are controlled through the lower brain gateway using the vagus nerve. When you're making your body work hard to coordinate functions such as heart rate, it gets too busy to process pain. And they're right. And if you're ever in a pain clinic, you'll see that there's definitely an emphasis on movement. There's an emphasis on exercise. The last thing we want you to do is lay in bed. Man, people, you got to get out of bed and start walking. Open the door, walk out your front door. Do that at least once a day, even if you're in agonizing pain. If you can do that, then I want you to walk your block. Walk a couple of houses to the left, walk a couple of houses to the right. Let's just start moving that body again. Because when you move that body, we're changing the way the brain is processing pain. And then this book is all about lots and lots of suggestions on foods, exercises, prebiotics, probiotics, ideas for positive memory association. So, for example, getting back to learned fear, my learned fear of driving in a car. She talks about how to change that. What instead of me thinking that car ride is going to hurt, what I have to instead say is, Jill, car rides haven't hurt for 15 freaking years. You drove up to Healdsburg last weekend and had a ball, right? Which was a 30-minute, 45-minute drive, which would have been impossible 20 years ago with my IC. But I can do that now. So anyway, listen, folks, again, they don't pay me for this. In my opinion, this is a really groundbreaking book. And it's simple, it's easy, it's short, it explains a lot that we really haven't spent a lot of time in the IC community talking about. And that is how to change your brain processing so that you're experiencing less pain, because it is indeed possible. These do work. And we've got decades of experience and research to prove that. And I really have to think, if I had never gotten that audio tape, The Power of Positive Thinking, would I be where I am now? No, I don't think so. I think I would have fallen down that spiral of negative thinking, anxiety, depression, and I don't know where I'd be. But I decided instead to fill my life with happy things. Who knew that when you do that, you distract the midbrain, and the midbrain then has a much harder time processing pain. You're occupying your pain in your brain in a different and equally effective way. So in this era where patients are being thrown off of their pain meds, seriously, we got to build our skills. We have to build our skills. And this is one way to do it. So here's the book. When It Hurts Down There by Dr. Angie Storr, and the website is whenithurts.com. I think you should get it. I think you should get it. I think it will be helpful for you. And I'm going to summarize a lot of it and put it on our website, especially about reducing pain and some of the new brain processing things. I just hadn't read it as cleanly and crisply as I had in this book. Okay. So again, they're not paying me. I don't even know her. I just got a copy of this book and I fell in love with it. So When It Hurts Down There, 15 Proven Techniques to Alleviate Pelvic Pain. What do you got to lose? Pain. Why not give it a shot? Okay. So I'm more than happy to take any questions that you have on your IC. So let's dive into questions. I get myself off of my soapbox. Shirley says, just came off a bad flare from eating dried pineapple. Yeah. You know, I used to get smoothies with pineapple juice, and hello, boy, were those painful. Pineapple juice definitely can be a bit more high in acid, so that does not surprise me at all. Amanda, does anyone with IC also suffer from endometriosis, and adenomyosis, and blepharitis from chronic dry eyes? The answer, Amanda, absolutely. IC is strongly related to endometriosis, and this book that I was just showing you has a big section on endometriosis, and though this book would be very, very good for you. Okay. It also talks about the endometriosis, how you should be changing your diet when you have endometriosis, which is something that I had not seen before. They talk specifically about foods that are estrogen mimickers and how important it is to avoid those. And it talks about when you're inflamed, your body grows more nerves and yada, yada, yada. Okay. I also have very, very dry eyes. But Amanda, I think it's important for us to talk very quickly about Elmeron. I don't know if you've taken Elmeron, but Elmeron has now been linked to severe eye disease. This was research that was released in August. And in our survey, we have about 700 patients so far who have completed our Elmeron eye survey. And I will tell you that chronic dry eyes is one of those common symptoms that these patients are reporting. So if you're taking Elmeron and you're suffering from eye issues, it's really important that you come to our website, you read that blog on it, and then show that to your doctor. Okay. Marie says, I would like to talk to my doctor about disability. Any advice? Yeah, let's talk about disability for a moment. So there are 3 different types of disability insurance here in the United States. You've got private disability insurance, which usually comes from an employer. You've got state insurance, also known as SDI, that comes from your state government. And then you have federal insurance through the Social Security Administration. And there are 2 different types of federal insurance. There's SSI and SSA. SSI is for people who are impoverished, and the payment for that is, the payment in SSI is tiny, but it's for some people, it's what they need. Social Security disability is the disability that you pay for through your paycheck. And so you're not qualified for it unless you have had Social Security deductions out of your paycheck. So let's talk about them for a moment. So state insurance, disability insurance, SDI, is short-term disability insurance. It is the insurance you use when you break your leg, or you have a baby, or you have to have surgery. The goal of state insurance is to tide you over until you heal and you can go back to work. So state insurance only has a limited period of time. Usually it's a year. Okay. I took state insurance for a year after I got laid off from my job because of my IC. Okay. But again, the intention of state insurance is that they want you to go back to work, and you believe you will go back to work. And in fact, when you're getting state insurance, you can actually go back to work, even part-time, and you just report your income, and then they reduce your check a little bit to compensate for that. So the intention of state disability is short-term. It is remarkably easy to get. You literally just go to the website, get a form, take it to your doctor signs it, And whether it's for a month or 6 months or 9 months or just 3 weeks, SDI is a lifesaver for many patients. Okay. Federal Social Security disability has a different intent. The intent of federal disability is that you will not be able to work again. So the intention is not to get you back to work. So the standards are different for SDI. So number one, you have to have worked and paid into the system 40 quarters, unless you're under the age of 30, and then they have an age test. And that's why, guys, seriously, if you're working part-time, you always file a tax return, and so that you can get your quarter. Even if you made bare bones pennies, having that quarter of coverage is critical because it will help you apply for your retirement benefits and your disability benefits. Okay, so the assumption here is that you've worked into the system and you meet the work test and you paid into the system. So and this is not an entitlement as we see people talking about. This is an insurance program that you're paying for. Okay. To be successful in SDI, number one, you have to have at least one doctor saying that they do not believe you will be able to work. You may not be able to perform, quote, the essential functions of your job. So if your job is lifting, you cannot lift anymore. If your job is sitting at a computer and you have a spinal injury, you cannot sit anymore or stand or whatever. So you have to have doctor support, ideally a couple of doctor support. Now, there may be a time where you've got some doctors who say, I won't sign that. And that's okay. You just go to another doctor, go to your primary care, go to your OBGYN, see if they will support this application instead. And then when you make the application, interstitial cystitis is not an automatic approval. However, there is a Social Security guideline that supports interstitial cystitis applications, but you have to really be prepared to talk about anything and everything that is interfering with your ability to work. So if you got bladder pain and you pee every 5 minutes, that's valid. If you've got IBS and you have diarrhea every day or constipation every day or whatever, that goes in there. If you struggle with depression, that goes in there. If you've got a knee injury, that goes in there. We're trying to build a case that shows and proves and demonstrates that your body is so limited that you cannot work again. Now, that was my first job after college. So I worked for Social Security for a year, which was creepy. It was pretty a bad work experience overall. But they're not against you. They're not against you. But however, it's really rare that they grant an automatic approval. Like 98% of people who apply for Social Security disability are denied. And you cannot take that personally. You cannot be upset with that. That's, in my opinion, their way of sorting the wheat from the chaff. Because for people who don't request a reconsideration within 30 days, Social Security's attitude is, well, maybe they're not that disabled. Maybe it's not that important to them. So it's all getting that first denial letter. It's almost a test of your will. And so when you get denied, you'll have 30 days to appeal it. It's called a reconsideration. You always appeal it. Always. Most patients are approved at that point when you appeal it. Now, another thing that you've got to understand about getting through the Social Security disability process is subjective. It's not objective. So it's not like we've got a medical test other than a hydrodistension and biopsy that can show them how intense your pain is. And so a lot of it is opinion. They look at it as opinion as compared to facts. And if you happen to get an examiner who is a little bit more judgmental they're going to go, well, I see nothing in here that shows that this person has to pee a lot. Therefore, it's their opinion. I don't believe them. They want objective evidence. So you've got to give them objective evidence. So how do you do that? On our website, in our free download area, we have a medical records file. It's free. People, go to the IC Network website, go to the free download area, and download this, okay? And in this, it has, you know, who your doctors are. It has who your physical therapist, all that sort of stuff. It also has a section, diagnostic and testing history, right? So I want you to fill out every freaking test you've had, every single one of them. All your urine tests, everything. This is powerful data to support your Social Security application. And I have a lot of space for it, man. I got room here for 20 tests. Oh, more than that. It also has a treatment history area where I want you to write down your treatment. What was the treatment supposed to do? What dosage did they want you to do? How long did you take it? What were the side effects? The name of the doctor that prescribed it. Again, this is hard, tangible data that you can use to show any Social Security reviewer just how hard you've worked to try to get your health back. Because seriously, nobody wants to be on disability unless they're, you know, a con artist and they're just freaking lazy. Most of us with IC, God, we want to work. We want to contribute to our family, you know? So anyway, you have to show them the work that you've done to try to regain your health, okay? There's a pelvic floor therapy log. There's your emergency care instructions. This is important too. If you're incapacitated for some reason, what do you want the doctor to know? You want the doctor to know, hey, please don't use a regular catheter. Please use a pediatric catheter. This is something that you give to your family also that will convey to them your deepest worries and concerns should something happen. And for me, it's all about catheterization. Seriously, you're not going to stick a big, giant rubber red catheter in my urethra. No, and that's there, right? Okay, but the real important thing is you're avoiding in pain diary. Basically, you write down the time that you pee, an approximate volume. You don't have to measure it. Your pain level on a scale of 1 to 10 and any notes. And you give this at every appointment. You give your doctor a 3-day voiding in pain diary. And that, my friends, is evidence. So we had a case, I did it on our website, in our Disability Resource Center. I worked with the only patient who went all the way up to a federal judge to get her IC. And this was 15 years ago, 17 years ago. So she was initially denied, then she filed a reconsideration, she was denied, then she appealed that, and she was denied, and yada, yada, yada. And she kept fighting. She's a real hero. And the reason why the judge denied her is he said, there's no proof she has to pay. There's no proof. And the doctor didn't witness it. And his argument was, if she had to pee every 10 minutes, the doctor would have made a note of it because he would have witnessed it in her appointments. And he said, this person is not worth coverage because there's no proof. And in her appeal to the federal court, she argued and won, saying doctors do not observe frequency in the middle of the night or during the day, that it is impossible for a doctor to observe real-time urinary frequency and how IC is disabling to a patient. And the federal judge ruled in her favor, and she got 5 years. I mean, it took a long time for her to get through the process. She got a huge a huge reward for that. But more importantly, she got gratitude from the IC community because she prevailed and she taught us an important lesson. If she had had a voiding and pain diary in her medical file, she would have been approved at the second level, but she didn't. So learn from that, okay? If your symptoms are really severe and you're thinking that disability is in your future or short or long-term future, start gathering your data to prove it. And a voiding and pain diary will establish that for you, okay? Stacy asks, am I selling the book on the site? No, I'm not. Not that I'm going to try. I probably am going to want to. Just go to whenithurts.com. Whenithurts.com. And I'm not sure how it is. I mean, it says on the back that it's $35. I think it's worth it. But if I can get it, I will contact them on Monday and see if they'll sell it to me wholesale and see if I can get it to you for a cheaper price. Okay. Okay, so Amanda says she also has kidney stones and a lot of surgeries and constant UTIs with E. coli and blood in your urine. Okay, so Amanda, if you have constant recurring UTIs, what that means is that you either have a drug-resistant E. coli, and believe me, E. coli is the master at defeating antibiotics. It's amazing what E. coli does. One of the things that E. coli does is when it senses, let's see, I want to get this, okay. I think when it senses an antibiotic, it changes shape. It goes from being kind of round to being a noodle, a long noodle. And when the white blood cells arrive to fight that infection, it doesn't recognize the noodle as an infection. And that was researched by a very good doctor called Scott Holtgren. He is the leader with E. coli-based drug-resistant infections. Okay, but anyway, seriously, girl, if you're getting recurring infections, you either have a drug-resistant infection or you've got something in your daily life that is making you vulnerable to infection, and or you might be menopausal, because when you're menopausal, you don't have as much mucus. Therefore, it's easier for bacteria to burrow into your cells, okay? Your next step is next generation DNA urine testing. Go to bladderhealth.org and learn about it. Because this is going to find this is going to find any drug resistance genes. It's also going to identify much more accurately the type of E. coli that it is, and it will give you really good antibiotic testing results. So anytime you have recurring infection over and over and over, and you're not responding to therapy, this is the next step. And it's so important. I built the whole website for it earlier this year, bladderhealth.org. So come to this website and learn about that, okay? And remember, when you've got active infection, your bladder is probably going to be bleeding to a certain extent. All right. Let's keep going with your questions. Jerry says, I don't know any triggers except too much coffee, and I don't have sharp pain. Sherry, there are a lot of dietary triggers. I mean, it's going to be acids, it's going to be caffeine, anything that's neurostimulatory that amps our nerves up. Remember, we're talking about controlling neuroinflammation. We're talking about controlling pain in the brain. The last thing we want to do is hit the nerves with a jackhammer, which is what caffeine does. So come to our website and read about that, because we talk a lot about, we have several blogs and articles about the most common food triggers for IC. Lisa, what did we say should be in your probiotics? It is, hold on, and I can tell you. Let's see if I can find this. It's 3 different species. Okay. It's on page 41 of the book. The specific bacteria that have been shown by data to work are lactobacilli, which we know, lactobacillus, that's the most common probiotic. Bifidobacteria, and you definitely see more. We've been talking about bifidobacteria for many years. And then also a type of Streptococcus, Streptococcus faecium. I don't know. I never know if I should show it to you like that. I don't know if you can read it or not. And the best source is a living source, ideally from something like a Greek yogurt. If you're lactose intolerant, try a coconut milk yogurt. That's what I do. I do coconut milk yogurt. Or, yeah, that's my preference. All right. Hello, David. Hello, Sherry. Who is the author? The author is Dr. Angie Storer, Stoehr. She's an OBGYN. Rena, I cuss. I will cuss more. I've never cussed so much in my life than I have in the last 2 years, and you know why. Okay. Kathy says, my new urologist wants me to have a urodynamic evaluation in the office. What do you think about this? Okay, so Kathy, in a urodynamics, really all they're doing is they're testing your nervous system down there. We want to see if the nerves in your bladder are functioning normally to help you void and help you empty your bladder. So how do they do that? You know what? Okay, is that okay? Okay. I care for 2 elderly people, and I thought I heard one of them cry out, but no. I can hear them laughing. Okay. Okay. So when you have a urodynamics, what they're going to do is they're going to slowly fill your bladder with fluid. And then they're going to ask you a question. They're going to say, when do you first feel the need to pee? When do you first feel that need to void? And then they're going to push it a little bit more, put a little bit more fluid in there. And then they're going to go, okay, tell us when you first feel pain, right? And then they might push a little bit past that just to see how far you can go. And that really assesses something that we call waking bladder capacity as compared to anesthetized bladder capacity. When you're awake and all your nerves are functioning and working, you're going to react more. You're going to feel more. Whereas if you were under anesthesia, they'd probably be able to put twice as much urine in there. So it's just a normal test to understand your bladder functioning. Urodynamics is, however, not considered an important test for a diagnosis of IC. And we have many articles that have argued for urodynamics and against urodynamics. And I do believe the American Urology Association, in their guidelines, say it's only done if your diagnosis is in doubt and they're really trying to figure stuff out. Nanda, no time to meditate with 3 children. Yeah, right before you go to bed when they're asleep. That's your only shot. Sherry says, even when I'm in pain, if I get an invite to go out, I hop into the shower, my pain level drops, and I go out and my pain almost goes away. So someone call me and invite me on a date. I like that. I like that a lot. And that's really true. You know, isn't it interesting how, like, for me, if I'm feeling sick and I think, and I'm starting to get that kind of anxious, maybe I better go to the doctor. And then I get worse. I get sicker. And I feel worse and worse. And then I call urgent care, and then I go to urgent care, and I'm walking into urgent care, and I'm just feeling like I'm just going to drop. And then you see the doctor, and the doctor goes, oh, completely explainable. We know exactly what this is. No sweat. Here's what we're going to do about it. And you walk out, and your pain is miraculously gone, or much, much less. And that's kind of an example of kind of that midbrain functioning. So you're right. You're right, girl. Distraction and positive thinking, definitely. Sarah says, distraction and positive thinking help. When I'm down and feeling sorry for myself, it's much worse. I just feel more down, but sometimes it's hard to snap yourself out of it. Yeah, exactly. Sarah, you nailed it. Exactly. And again, I'm kind of, I think that one of the things that patients do that is a really, really bad mistake is you stay in your bedroom with the drapes closed and you just lay in bed. That's not going to get you any better, man. You got to open those drapes, let the sunshine in, sit up, start moving. When you move, you start distracting your brain. It helps, especially with chronic pain. Hello, Corrine from Belgium. Very, very nice to meet you. Amanda says, has anybody else had kidney stones before being diagnosed with IC? Amanda, we have a really interesting case of a patient who was diagnosed with IC years ago, but she was afraid to have a cystoscopy, so she never let anybody look in her bladder. And when that finally happened earlier this year, what they found was a giant kidney stone, a giant calcium oxalate kidney stone floating in her a bladder, cutting her bladder wall, because kidney stones are very, very sharp. And so if you've got one, I mean, when we think about an IC bladder, and kind of here's a picture of an IC subtype 2 bladder wall injury, and we see kind of these petechial hemorrhaging and things like this, you know, one of the questions is, well, what causes some of this? And this is a perfect example of what a floating kidney stone could do to your bladder, because it's sharp. It's just like jabs you and cuts you wherever you are. That's not true for everyone, but it is for some people. Sherry is asking, is cognitive behavioral therapy new? The answer, the book is new. Cognitive behavioral therapy is not new. We've known about it for years. In fact, 25 years ago, my urologist recommended that I read a book on it. But now we understand more about why it's helpful, what it does. You know, I mean, I'm the perfect example of somebody who was incredibly offended when somebody suggested that I try therapy for my IC. It's like, are you kidding me? My bladder is screaming. I don't need you to mess with my head. And that shows my lack of knowledge about it 25 years ago, because now we're not saying IC is all in your head. We're not saying your head is causing your bladder disease or your bladder injury. But what we are saying is that your brain will influences your pain levels. And so if we can work to control the low brain, the midbrain, and the upper brain in different ways to distract it from pain, your pain might be less. And that is why when one of the girls in here said, when she gets an invite, she goes and takes a shower and starts moving around. And that's really distracting the mid portion of the brain so that it cannot concentrate on the pain sensation. Distraction works. Okay. DP is Bindra is saying, are there any medication for bladder coating? So again, we're thinking about this as injury or trauma. And so this is an example of an injured bladder. And of course, the challenge with a wound in the bladder is there's always urine in our bladder. Always urine in our bladder. And urine finds the wound, it goes into the wound, and it hurts. So creating an environment that will help the bladder heal is pretty challenging because we've got urine in there all the time. So one of the ways we do that, of course, is you don't do acids, because when you do drink lemonade and it gets into one of these wounds, it kills that wound and it hurts like hell. But what you can do also is do something that has a bladder coating effect. And so the three most popular bladder coatings here in the United States are going to be CystoRenew, CystoProtect, or Desert Harvest Aloe. These are over-the-counter supplements that have a bladder coating effect. Or if you want a treatment with a bladder coating, you could do a rescue installation with heparin and lidocaine. The heparin is the coating, the lidocaine numbs the nerves. Or you could do something like Elmeron, which is kind of a chemical Band-Aid. But the ultimate flaw with Elmeron is, if you swallowed a Band-Aid, would it come out the other end of Band-Aid? And the answer is no. Hello, we have digestion. And so 92 to 93% of Elmeron is inactive by the gut, and you just poop it out. Only 7% makes it actually to the bladder. And that's why you have to take a lot of it over a long period of time, because so little of it actually makes it to the bladder when you take it by mouth. But if you just have them put it in your bladder in a Elmeron cocktail, then 100% of the medication arrives in the bladder. So putting it in the bladder directly is a far more effective way of putting a chemical coating or a chemical Band-Aid in the bladder. But again, now we have really compelling information showing that long-term use of Elmeron is linked to macular and eye disease. So, that, again, we want to perhaps start with the supplements instead, because they have much fewer side effects, and also they don't cost thousands of dollars. Elmeron can cost $1,800, $2,000 a month for a prescription, whereas a supplement can cost under $50 a month. Okay. Alexis, is IC related to any autoimmune diseases? The answer is yes. In our subtyping system, we have 5 fundamental subtypes, but then in each subtype, there are subtypes. There are little variations. And there definitely is a small subtype where a small group of patients, and I think the research was 3%, have other autoimmune related conditions such as Sjogren's syndrome, lupus, rheumatoid arthritis, things like that. And do we understand why that happens? No. IC by itself does not meet the strict criteria as an autoimmune disease. However, there is no doubt that there is this small group of patients who do have some autoimmunity issues going on. And she does talk about that in this book. She talks about autoimmunity in this book to a certain degree. All right. Amy says, thank you for the bracelet, diet card, and book. I'm glad you got it. A couple weeks ago, we gave away a whole bunch of books. And then this week, in the middle of the week, we gave a whole bunch of Desert Harvest aloe samples. And I'm out of aloe samples now. Not that I won't have any in the future. But if you send me your name and address, I will send you our food card, our diet card, which is here. Okay, so here's our freebie for today. If you send me your name and address, I will send you our restroom access card and our diet card. Oh, come on. See, the light is so weird here. It's so bright. Okay, usually bladder friendly. If you want both of these cards, you need to send me your name and address, and you're going to send that to icnetwork@mac.com. So every meeting I try to have freebies. So our freebie this time, restroom access cards and diet cards, icnetwork@mac.com. If you've already gotten freebies, that's fine. You can do it again. It's okay. Because if you don't have the restroom access card, feel free to ask for it again. Just put in your email you already have the diet card, or even if you want another one, that's fine. All right. Laura says, Sjogren's syndrome causes dry eye and is common with IC. I know it's spelled wrong. Yeah, I have Sjogren's syndrome myself. I have extremely dry eyes, but I have a variation of Sjogren's syndrome called Sika, which is known for just causing dry eyes, dry mouth. And my mouth is fine, but my eyes are ridiculously dry. But again, in the research studies, the rate of Sjogren's syndrome in the IC patient population is, I think, between 3 and 5%. So it's not common. It's not common. Amanda says, since I can't do probiotics, which yogurt did you say would be best? Like a coconut milk yogurt, Amanda, or a Greek yogurt, but a coconut milk yogurt I think would be reasonable. You could give it a try. But of course, talk to your doctor since you've got some pretty other major medical issues. Your doctor might have some other ideas. Hello, Jamie from Mississippi. Amanda has been trying for 5 years for SSDI. Yeah, girl, don't give up. You got to keep working at it. But at the same time, girl, it's been 5 years. Can you imagine the power of 5 years of voiding diaries in your medical file? It would be undeniable that you have bladder pain and you're peeing a lot. So if you haven't done that, start doing it. Start doing your voiding diary. Oh, how is the sound, guys? Here. Oh, you know what? Oh, my God. I didn't do my sound test. Is that better from a sound standpoint? Perfection is not an option. Hopefully, the sound has improved with this. I've been told by 5 specialists that I have the worst condition that they have ever seen. Need help. My current doctor has cut me back to 15 hydrocodone, or one 5 milligram hydrocodone a day. So, Jamie, ultimately, you have to know what your IC subtype is first. You know, yes, there are patients that are extremely complex. You'd be amazed at the number of patients who call us who say they've been told that they have the worst they've ever seen. But when we spend a little bit of time subtyping them, it helps us understand why they're struggling to get help and why they're struggling to find the right treatment for them. And so we have 5 core subtypes for IC. Let's go over these, and then I want you to think about which subtype you think you might have. You can have more than one subtype. So again, with the tremendous diversity and variation in the IC patient population, we know a one-treatment-fits-all approach does not work. Why? Because there are different types of IC. Again, we've got patients with bloody bladder walls versus patients with a healthy bladder, like myself. Both diagnosed with IC, yet clearly we're not the same. We've got patients with pain, none with others with just frequency. Both diagnosed with IC, clearly they're very different. But you really see the diversity in how patient symptoms began. So when you ask patients what triggered your symptoms, that's where it's the most fascinating. Because for some people, IC begins in childhood, whereas for others, IC begins in their old age. For some people, IC begins after an infection. For some, IC begins after chemotherapy or a chemical exposure. For some, IC can begin after a fall or a car accident. For others, IC can begin after sexual abuse. Okay? So clearly, a one-treatment-fits-all approach does not work because of this diversity. So for the last decade now, doctors have been trying to understand these unique variations, because when we know what your variation is, we know how to point you to the right treatment. Because if you've taken Elmeron for 15 years or 10 years and it's never changed your symptoms, then that's not your subtype. And so the purpose of subtyping is to help you focus on the right treatment for your unique case. In Europe, there are 16 subtypes, and they've had 16 subtypes for a decade. In Canada, they use the U-point system, which is 6 subtypes. In America, we have not agreed on a subtyping system. However, I personally like the subtyping system created by Dr. Christopher Payne, who ran the IC research program at Stanford University out here in California. So if you've been on the West Coast, the odds are you've heard the name Christopher Payne before, because he has been doing IC research for 20 years, and he's an absolutely lovely man. And he and his wife now own Vista Urology, which is the #1 pelvic pain center in California. So he wrote an article a few years ago where he said, and he's so right, he said, you know, when you diagnose as a patient with IC, you're just, it's like you're throwing them into a void because there's no obvious treatment pathway. And he compares it to cancer. He said, listen, when you're diagnosed with cancer, you're given a very specific diagnosis. You have cancer of the left breast that is estrogen dependent, type 1, 2, 3, 4. Or me, last year, complex endometrial hyperplasia with atypia and a vague architectural complex. in a cancer diagnosis, it is so specific that both you and your doctor know exactly what you need to do next. Like for me, hysterectomy. And he argues that that does not happen when you diagnose somebody with IC, that you don't know what to do next. The doctor doesn't know what to do next, and you don't know what to do next. There's no intuitive pathway. Now, how do we get an intuitive pathway for a diagnosis of IC? We do it with a subtype. We do it with a subtype. We need specificity. So here are his subtypes. IC subtype 1, Hunner's lesions. Okay, everyone in the world agrees. Every doctor, every researcher in the world agrees that a patient with Hunner's lesions is their own unique entity. And we know Hunner's lesions are a different disease process because when you biopsy a Hunner's lesion, it looks different than everybody else. Hunner's lesions are filled with inflammation, massive inflammation. Whereas I have no inflammation in my bladder at all. Okay. We also now know that Hunner's lesions don't respond to Elmeron. They don't respond to typical bladder treatments. You have to do what we call lesion-specific therapy. If you treat the lesion, then that patient's pain generally improves, if not goes away. And we can talk about that in a bit. Hunner's lesions, the theory behind Hunner's lesions, number one, it's either a nerve that's stuck in a massive inflammatory pattern. We call it neuroinflammation. When nerves are irritated, they release something called substance P, which causes tissue to break down. So theory number one with Hunner's lesions is that it is a nerve that is massively inflamed, which would explain why Elmeron wouldn't work for that. Okay, theory number two with Hunner's lesions is that it could be a virus on that nerve. We now have multiple research studies that have found different viruses in the urine of patients with Hunner's lesions. And who knew? Again, you know, we're all thinking with the bladder, you're thinking bladder infection, you're thinking bacteria. You're not thinking virus, and you're not thinking fungus. And now we have evidence that both of those can be found in IC patients. But we have some research that shows that the polyoma BK virus and the Epstein-Barr virus have been found in the urine of patients with lesions. And you can read about that more on our website. Okay? So if you've got Hunner's lesions, you're going to be focusing on lesion-specific therapy. Okay? And we'll talk about that later in this meeting, and or we'll talk about, you can go to our website and read about it. I have a whole section on Hunner's lesions. IC subtype 2, bladder wall driven. So these are the patients where there is some sort of dysfunction or damage to the bladder wall that is driving their symptoms. So the perfect example is chemical injury, chemotherapy. We call it chemo-induced cystitis. I was working with a man actually with chemo-induced cystitis for the last couple of months, and he finally emailed me to tell me that his symptoms had improved. Chemicals can badly irritate the bladder wall. Also in this subtype is chronic infection. There can be a small group. I do believe that there is a small group of patients who have a chronic fastidious infection deep in their bladder. It's not everyone. It's a small group. And again, how would you know if you have that? You would get the next generation testing. Here it is. If you think you've got infection, you know, step number one, is you do an azo dipstick. But if that comes back negative, but you're absolutely convinced that there's something that they've missed, this is what you can do. Do next generation urine testing. It costs $199. They will send you a kit. You pee, you send it to them, and they will give you a readout of all the bacteria and all the fungi in your bladder. We also know now that many patients who are struggling with IC flares actually have an overgrowth of candida in their urine, and that's from our own National Institutes of Health. Typical urine tests don't test for candida. Next generation testing will find any fungi in your bladder that could be contributing to your symptoms. So this is really a game changer for us. what else can cause bladder wall-driven symptoms? Menopause. So if we look at this picture, this is a side view of the bladder wall. So we've got a layer of mucus. This is turquoise layer. We've got your typical urothelium, your cells of your bladder, and underneath that we've got blood vessels and nerves. This mucus is estrogen dependent. So when you're young and you have lots of mucus, lots of estrogen, you have lots of mucus. Therefore, the irritants in your urine can't get here and cause problems. And the bacteria in your urine cannot get here and cause problems. Unfortunately, as we get older, we lose estrogen. And as we lose estrogen, guess what? We lose mucus. And when you lose mucus, what happens? Irritants of urine, bacteria in your urine can penetrate more deeply into the bladder wall and cause problems. Frequency, urgency, pressure, pain. This is not a disease process for an older woman. This is menopause. And this is when we would be doing a bladder coating therapy. This is Elmeron. This is an example of, this is an Elmeron educational tool. Or they might give you a little bit of estrogen and to use vaginally so that your body can actually produce more mucus. So we know your bladder wall is driving your pain. If you have pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And as soon as you empty your bladder, you feel better. It's like, thank God I found a bathroom. And this makes sense. So think about it. If you have a wounded bladder and you're standing up, urine starts at the bottom and builds and fills your bladder. And wherever it fills your bladder, it's entering those wounds. And that hurts. So the fuller you get, the worse you feel. And then as soon as you empty your bladder, urine is no longer touching those wounds and you have a sense of relief. So if you have pain as your bladder fills with urine that is relieved by urination, that is pointing us to your bladder wall, that is pointing us either to Hunner's lesions or bladder wall injury. Okay? IC subtype 3 is pelvic floor driven. So this is the largest subtype. So these are the patients whose symptoms are being driven by injured pelvic floor muscles. This is, again, the largest subtype. So if your IC began after a fall, after a car accident, after a rape, after having a baby, then we're going to be looking, it's not to your bladder, but we're going to be looking to your muscles instead. Now, it might surprise you to learn that muscles can trigger bladder symptoms, but they do. And let me explain why. I have to get my little demo here. Okay, so here's your pelvic floor muscles. They go from hip bone to hip bone. They go from front to back. They go from side to side. They go from low to high. And your pelvic floor's job is to support your organs and to support your body. It's part of your core. In fact, that book talked about something. I got to find that for you. Okay, so when you tweak or injure these pelvic floor muscles, what happens is they get weak. And when they get weak, they know that they have a job to do. They can't stop doing the job. So they overcompensate. And the way they overcompensate is they get tight. And when they get tight, number one, you can see it's hard to pee or poop when your muscles are tight. It's hard to have sex, hard for things to go out, hard for things to come in when your pelvic floor muscles are tight. And if you squeeze your arm, okay, and then let it go, and you can see that it turns white. And then very quickly, the blood flow goes back because muscle tension restricts blood flow. And when you restrict blood flow to the organs in the pelvis, they cannot be healthy. And that includes the bladder, and that includes the vulva, vulvodynia, and that includes the pelvic floor muscles in general. We need good blood flow. Okay? So for these people, they tend not to have pain before they pee. They tend to have pain after they're done peeing. So if you hate going to the bathroom because you know it's going to hurt so bad, it's going to hurt. Or somebody asked earlier, they asked me to talk about Kegel exercises. Somebody with tight pelvic floor muscles cannot do Kegels because Kegels are designed to tighten muscles. Well, we don't want to tighten muscles that are already too tight. If I do a Kegel, it hurts because my muscles are too tight. Instead, what we're going to focus on therapeutically for these patients is restoring blood flow and muscle function by relaxing muscles. Okay? So for these patients, rather than doing Elmeron or a bladder therapy, we're going to be doing pelvic floor physical therapy. And if you're having a pelvic floor flare, you know, we're not going to be worried as much about alkalinizing your urine as we are going to be about breaking those muscles out of tension and a muscle spasm with heat. I was having muscle spasms yesterday, as a matter of fact. Grabbed a heating pad, laid down, read a book, heat on my pelvis to really try to stop those muscles. Okay. IC subtype 4 is pudendal neuralgia. This is a nerve injury. So these are the patients whose symptoms are nerve driven. This is a much smaller subtype, and their symptoms are positional in nature. You're fine when you stand, but when you sit down, it hurts. Or when you squat down, or when you bend over, movement triggers their pain. And it's nerve pain. It's sciatica-like pain. It's sharp. Ow, I've been shocked by, you know, an electric socket type of pain. And for these patients, we're still looking at muscles. Generally, the reason why there's a pudendal neuralgia is because those muscles are so tight, they are constricting a nerve. And let me show you a picture from this book. I thought it was pretty cool. Let's see here. Let me see if I can find this. I thought it was pretty cool. One of the things she talks about in here, by the way, is okay. So getting back to subtype 3 for a moment, pelvic floor. There are many muscles and fascia in the pelvis. It's a really busy place. The muscles and fascia in your pelvis serve to hold up your insides when you sit and stand and help you use the bathroom. Think of it like a hammock. When you stand up, normally most of the pressure of your upper body is pointed over your hip bones towards your pubic bone and transforms down into your leg bones. When you tilt your pelvic bones backwards, all of a sudden the whole pressure of your upper body is resting on the middle of your pelvic muscle hammock. Those muscles aren't meant to hold up so much weight. So the muscles fatigue and start getting knots in them. These knots then become an additional source of pain. You know, I was working with a dancer earlier this year, a young dancer. She danced for years. And, you know, we have long known that ballerinas seem to be particularly prone to pelvic floor dysfunction. So think about, oh, darn it, I'm wearing black. That doesn't help. All right. So think about it. So we're standing normally, and I wish you could see. I'm trying to get this right. Okay, so if you're standing normally, you're like this, right? But dancers are taught to tuck. You're taught to bring your pelvis in. I know this because I did ballet for a while. Okay, so you're taught to kind of crunch your belly, pelvic in, and then, you know, you do what you need to do, and to do your dance move. And what she's saying right here is that's one of the things that puts way too much pressure on your pelvic floor. And that's, again, why we think so many dancers, especially younger dancers, if you started dancing at the age of 5, by the time you're in your 20s, you could have some really significant pelvic floor stuff. All right, so getting back to the nerve thing, I want to find this real quick. Hold on a second. Where is it? Where is it? I thought it was a really good, cool picture. Is that it? Yeah, here it is. Okay, so look at this now. So one of the points that she makes in this book is that there are a lot of nerves in your pelvis, nerves that go to your bladder, nerves that go to your reproductive system, nerves that go all over the place. And this is kind of her picture of it. You can see all of these different nerves in different parts of the pelvis. And they all end up going up to pretty much the same place up in the spinal cord, L4, L5. And one of the things that makes pelvic pain so challenging for the brain is that these messages get mixed up. That because they all get so concentrated here at the spinal cord, that it takes a lot of work for the brain, and it takes a lot of work for you as the patient to try to describe where your pain is. It's hard. It can be hard. Okay. So again, for IC subtype 4, pudendal neuralgia, really our therapeutic priority is going to be to calm and relax muscles, because we don't want them to impinge on nerves. And we're going to do nerve calming therapies, nerve calming medication perhaps. And then IC subtype 5, central sensitization, is the last subtype. This is my subtype. This is the inherited subtype. For some of us, IC goes back 3 generations in my family. It's characterized by very sensitive skin. We are drug sensitive. We are food sensitive. We have an exquisite sense of smell. And we happen to have a very sensitive bladder, a very sensitive stomach, a very sensitive bowel, a very sensitive vulva, a very sensitive rectum. We are a walking, talking sensitivity. And I've talked a lot about that before. This, again, is not central sensitization. Either is the gift of our ancestry, or it can happen after some sort of traumatic injury. And so in my case, it runs in my family, my grandmother, my aunt, my sister, my cousins, my mother, my brother, we all, hello, redhead, super sensitive skin. Thus, it makes total sense that we would have other sensitivities in our body. And for us, our treatment priority is going to be to calm and soothe those nerves. Generally, somebody with central sensitization, we don't want to do aggressive things that turn nerves on, like aggressive testing. We're going to be very calming and soothing and gentle and respectful of that. So I've talked a lot about central sensitization in a lot of these past issues. Okay, so getting back to who I was responding to here, ultimately in the end, Jamie, what we first have to do is we have to figure out your subtype. And then let's look at the treatments you've done to see if they, in fact, are effective with that subtype. If, for example, you've been diagnosed with Hunter's lesions and they've never treated your lesions, that's why you're so bad. And we have to treat those lesions. So if you, Hun, want to call me this week, I would love to talk with you and meet you. And maybe we can do a little bit of brainstorming, and we can try to subtype you a little bit more and come up with a better treatment plan, right? Or at least some treatment ideas to talk to your doctor about. So our website is ic-network.com, and our phone number is 1-800-928-7496. We have a patient support phone line you can call. I answer that phone almost every day. And I would love to just talk with you and see if we can come up with some other options for you, my dear. Okay? All right. We're going back to your questions. Stacy, you're right. I love talking with patients. Melissa says she was denied 3 times. She fought 5 years and finally won her disability. Had to get back pay for 5 years. Hey, man, I bet that was a nice check. And yes, you did have to go in front of a judge. And patients shouldn't, listen, don't be afraid to go in front of a judge. That's when you really get to tell your story. That's where patients are approved more frequently, is in front of a judge. I'm just going through your questions here because you guys are talking to each other too here. Lori, I had both my fallopian tubes removed in June, been in pain ever since. Urologist treating for me for IC, even though the scope of my bladder showed nothing. Taking Cystitis Renew seems to be helping, and ordered the next gen. Can the type of surgery cause pelvic floor problems? Absolutely. Oh my God. Yeah. Did they, you know, any type of pelvic surgery is going to influence nerves and influence muscles. And I am still recovering from my hysterectomy 15 months ago, which is why I mention it in almost every one of these, because it's something I live with every day. I had spasms yesterday from it. So the fact that your bladder showed nothing is good. That's good. That's good. That's good news. But I would really want you to have a pelvic floor assessment. Let's see if you've got any residual muscle tension from that procedure. And having the next urine test is interesting and might be helpful, because who knows, maybe you picked up some sort of nosocomial infection from the hospital. A nosocomial infection, guys, that sounds scary. It's not. It just means you picked up an infection at a medical center after a medical procedure. Unfortunately, infections from hospitals and medical procedures tend to be pretty vicious because they tend to be much more drug resistant. So can having your fallopian tubes removed cause pelvic floor problems? Oh, hell yes, definitely. I'm curious, so why they took the fallopian tubes, and did they take your ovaries too? Interesting. Hello, Heather. Hello, Heather. We have been joined. She probably joined about 15 minutes ago because I'm that far behind. Heather is with Desert Harvest Aloe. Her family owns the Desert Harvest Aloe company, and I showed this earlier. So the nice thing about, the thing that sets apart Desert Harvest from every other company is that they live and breathe respect for IC patients, to the point that they invest their money to prove that their product helps. So Desert Harvest Aloe is the only supplement company that did a double-blind placebo-controlled study to see if their product could help reduce the symptoms of IC. And yes, it did. The tragedy is, with the new FDA guidelines, companies are no longer allowed to put their own research on their websites. So even though they have really good research, they had to remove it from their website. All the companies had to, because the FDA says you can't use research for marketing purpose. My argument to the FDA is, but then how are patients supposed to find out if a product is useful or not? And so of all of the supplements, Desert Harvest is the one that has gone far and above all the other ones in really putting their money where their mouth is to see if this product helped to reduce IC symptoms, and it did. And I think we have a link to that study on our website. Alrighty. Okay, so nice to see you, Heather. Cheryl says, can allergies affect IC? The leaves of fall? Absolutely. Absolutely. And in fact, it's very normal for patients with allergies to go through basically a 2-month allergy flare. This was discussed last May in the IC course taught at the American Urology Association. And let's see, so I summarized the course in our magazine. This is our Summer IC Optimist. And they said, antihistamine medications inhibit mast cell release of histamines and can have a sedative effect, which we know. And I can explain that more if you want. But during allergy season, they suggested increasing the dosage and or using montelukast, especially in patients with a history of asthma. It was Dr. Lowell Parsons, the doctor who invented Elmeron, who first started talking about allergies years ago. And it was 1994 that I chaired my first IC conference, and he was our speaker. And so I was having lunch with him before one of those days. And he asked me, he goes, Jill, do you have allergies? And I'm like, yeah. And he goes, so we got this new medication that we've just started prescribing to patients, and it's really helping a lot of patients. It's called hydroxyzine, also known as Atarax or Vistaril. And he goes, you should try it. You should try it. We're still trying to figure out what it does, but it's helpful. And I will tell you that taking that antihistamine really changed my life. I took hydroxyzine pamoate, also known as Vistaril. And one of the things that it did for me, I used to have what I call sick all over days, where I just felt terribly ill. But I couldn't necessarily point anywhere. I couldn't tell you if it was my bladder or my bowel or my head. I just knew that I felt ill. And it was 5 out of 7 days a week. As soon as I started the hydroxyzine, it went away. And it was mind-blowing to me. It was shocking that within a week of taking it, I lost that whole body illness sensation. And that's kind of what taught me that a big part of my health relates to allergies. And so, Cheryl, absolutely allergies can affect IC. This is why hydroxyzine, also known as Atarax or Vistaril, is listed as a step 2 treatment option for IC patients. And using an antihistamine is real. Toby says, has anybody else been recommended Cymbalta for pain and anxiety and then experienced terrible symptoms getting off of it? Yes, Toby, we call that Cymbalta discontinuation syndrome. And wouldn't it be nice if a doctor actually told you that the medicine they're prescribing for you might be really hard to get off? And one of the problems with Cymbalta is that they don't have lower doses. So like you're already taking the lowest dose, right? And normally as we're trying to wean ourselves off medication, we go from low dose to a lower dose to a lower dose to a lower dose. Well, unfortunately, lower doses are not available. And so you're trying to get off of Cymbalta is incredibly hard. And you're not the first patient to have it. And it's like 6 months to a year of major distress in many, many ways. And anxiety is one of the really common side effects trying to get off of Cymbalta. So guys, you know, if anybody suggests that you take a new medication, you really need to ask the doctor, will this be easy to get off of? Once I start it, will I be able to get off of it? And if they say no, or if they say it's hard, you might want to revisit that. Cymbalta is a really hard medication to get off of. It's brutal to go through those 6 months afterwards. Just absolutely brutal, Toby. I feel for you big time. Terry says she had a stone stuck above the bladder over a year. So, Terry, is it in the ureter, or is it in the bladder, or is it above the urethra? Hopefully they can just go in and break it up with some ultrasound. Hi, Sheila. Hi, Roxanne. Do people experience problems or withdrawals when stopping Elmeron? No. Elmeron is not associated with any withdrawal symptoms because it really doesn't act on the brain in any meaningful way that I'm aware of. We asked Dr. Lowell Parsons at one of our conferences several years ago, one of the patients said, will I have to take Elmeron for the rest of my life? And his answer was no. But you have to figure out if it's helping you. So how do you do that? You reduce your dosage gradually. So what he said is if you take 4 a day, go to 3 a day for a week and see how you feel. If your symptoms get worse, then we know the 4 a day is working. If your symptoms don't get worse, then he says go to 2 a day. They don't get worse, go to 1 a day and slowly wean yourself off. The reason why he suggested doing it slowly is because if it turns out it's helping you, he doesn't want you to have to go through the 2 weeks to rebuild that coating. And so doing it gradually is really what makes sense. Roxanne asked if anybody's taken Toviaz. I'm not familiar with its use for IC, that's for sure. Deborah says, I have a bladder sling. Could this be causing my IC problems? I've had it since 2006, but more IC problems after menopause. So Deborah, absolutely. I just working with a patient on Friday, the same exact thing. Her symptoms started after they did a bladder sling. And in her case, I think her sling is way too tight because she literally couldn't sit for 6 months and is just now able to sit. And anytime, you know, when you have a prolapse, okay, so look, so here's your pelvic floor and here's your bladder or your uterus, right? And normally your pelvic floor holds it in place. But if your muscles become injured or weak, what happens is it starts moving downwards. And then before you know it, you've got a bladder sticking out of your vulva, out of your vagina. Okay. Or the same thing can happen with the rectum, where part of the rectum kind of prolapses and comes outside. So generally, when you're at the prolapse level, you're past the physical therapy point. It means your muscles have kind of stretched beyond the point of muscle work. So what they have to do is they have to do a suspension surgery. And they either use a mesh, which of course is very controversial, or they use your own tissue. So Deborah, what's challenging about it is it's really this part. Because if you think about it, how does the doctor know what the right tension is? So they've got their hand in your body, right? Usually vaginally, or if they have an abdominal, if you have an abdominal incision. So they with their gloves, they're feeling it. They're trying to find that right tension. They tighten it and they loosen it, and they're just guessing here. They're trying to find what will work for you. But there are moments when they just make it too tight. And you know fairly quickly it's too tight. And then the doctor can be somewhat reluctant to admit that it's too tight. And what they have to do is go in and surgically release it, which is what the girl I was just working with, I think, desperately needs, because she still literally can't walk up straight. Her muscle, there's something profoundly wrong with the way they did her bladder suspension. So yeah. You want to have a muscle assessment, Deborah? Let's get an idea of the quality and health of your muscles. But you also need an assessment, an objective assessment of your skin. You need eyeballs on your vulva. Have your doctor look at your vulva and see if there are signs of estrogen atrophy. Is it dry? If your vulva is dry, if your vagina is dry, then so is your bladder and so is your urethra. And that's when we're entering this phase where you just don't have that moisture you need. Thus, these things are penetrating into your bladder wall, and that would explain why you're having problems after menopause. So again, using a coating therapy would put a barrier in there, and/or they would also normally give you an estrogen cream if you can use it, if you don't have any other risk factors for it, to give your body the estrogen it needs to trigger the production of more mucus. It's called the genitourinary syndrome of menopause. Laura asks, are there studies about the long-term effects of desert harvest aloe? I don't know. And if Heather's still in here, maybe she will answer that question. I don't know if she's still in the room. Long-term studies are challenging. Number one is, how long-term is long-term? Is long-term a year? In some FDA studies, long-term is after 3 months. Whereas what do we know about Elmeron now? It looks like after 5 years, we're starting to see some eye damage, 5 years or longer. And can companies predict that? I know that's pretty tricky. Betso was recommended astragalus by an herbalist to support your immune system. What do you think? I don't have any experience with that at all. Roxanne, if you want the restroom access card, you need to send me, and a couple of people do this every time. Okay, you have to email me your name and address to icnetwork@mac.com. Do not just email me your email address. I cannot send anything to your email address. So send me your snail mail address to icnetwork@mac.com, and I will send you a restroom access card and a diet card. Terry said, your doctor told you that if you slinged your bladder, it could make your IC worse. Well, anytime you traumatize the pelvis and you influence muscles and nerves, yeah, your bladder is going to be more sensitive. But seriously, if you're at this point, you know, where your bladder is falling out, man, you got to do something. Even a pessary. A pessary is a thick object that they will put up your vagina to keep it in place. I've been working, one of my dearest IC customers and friends. She's in her 90s now. She just moved back to Virginia or North Carolina a couple years ago, and they found her prolapse when she was 80, and they didn't fix it. And now she's in her 90s, and her prolapse is very, very bad, and she's too old to have the surgery. So if you got a prolapse, and if it's repairable, better to do it earlier rather than later. Fred Green, seriously, we don't need comments like that in here. What exercises can we do to help pelvic pain? You want calming, or you want exercises that keep your hips level. So walking or the elliptical. We don't want you to do things that are running, you know, things that jar your hips up and down and up and down. I'll be going to the gym after this. I'm desperate to work out. Rowing would be really good. Elliptical would be good. You could do weights as long as you're not doing the exercises that traumatize your pelvic floor, like pulling your knees out or pushing your knees in. We have a section on our website that talks about exercise. Laura Bosser says, pelvic floor physical therapy did wonders for your pelvic floor dysfunction. I'm really, really glad to hear that. It really helped me. I just would like more of it. Karen, we will connect eventually if we... Maddie says, I'm having labor contraction pains. I can't get pain meds. I'm struggling. Well, listen, girl, if you're having muscle contraction pains, the medication you asked for is a muscle relaxant. So have you asked for something like Flexeril or Baclofen? That would be critical for relaxing the skeletal muscle of your pelvic floor, okay? Laura Bosser, does Jezra Harvest Style research have a lot of people involved? You'll have to talk to them. Lori, regrettably, they took your fallopian tubes. Okay. Okay, so they took your fallopian tubes for that, but you still have your ovaries. Well, that's a good thing, because believe me, you want your ovaries, because you need the hormone stabilization from your ovaries. So that's that makes sense. Hey, Jamie, nice to see you. Maddie says, you're on gabapentin for pain. What do we do for pain when we can't get pain meds? Girl, you use every over-the-counter option you can find. So we need you to use heat to relax your muscles. You would be looking at CBD, CBD oil from hemp or from medical marijuana. Medical marijuana, if it's legal in your state, absolutely worth trying, because it certainly is very good at relaxing muscles. We have, where is it? Essential oils. Oh, come on, where's my sample? Pro Serona NeuroQuell you can find on our in our store. They were created by the Endometriosis Association to help fight endometrial pain. It works well for some patients. There's something about the oil of the marigold plant that disrupts that pain nerve cycle. I use a lot of Tiger Balm myself, usually on my left butt cheek. So, and as Maddie, I started this meeting off talking about how do we modulate pain at the brain. And this is a new book that just came out, and I love it. And they don't even know I'm talking about it. They're not paying me for their endorsement, guys. It's called When It Hurts Down There, 15 Proven Techniques to Alleviate Pelvic Pain. And they do an excellent job here of talking about how you disrupt pain at different levels of the brain, because it goes up your spinal cord to your lower brain, to your midbrain, and your upper brain. And at each level, you have ways of distracting your brain from those pain, and so from pain messages, and it's amazing. It's absolutely amazing. So if you could, my dear, I want you to rewatch this video when it's posted, and watch the first 45 minutes, because that will go into it more. Terry says she has no bladder control, sick of spending money. Okay, so with no bladder control, we got to work on those pelvic floors, the pelvic floor muscles. All right. Okay, guys, if you have any questions, feel free to ask them. I'm down on YouTube now. Sandra says she was just prescribed methenamine for your daytime. So methenamine is commonly found in some of the typical medications. And I'm trying to remember. Uroblue is one. It would be very, very interesting to figure out why they suggested that to you, because methenamine tends to have a bit of a antibacterial effect. So is the doctor saying he thinks that your symptoms are being caused by bacteria? Or is he just throwing out something else at you? I would Google it, methenamine. And instead, again, I would ask you to subtype yourself a little bit more, see if we can figure out which variant of IC you might have. And that might give you a few more resources to use during the day. I mean, seriously, guys, if you've got pelvic floor dysfunction or pelvic pain, you should be taking hot baths or showers twice a day, morning and evening, to try to relax those pelvic floor muscles. That is a standard recommendation. Amy says, oh, hi, John. Amy says, how can I tell if my pelvic floor is too tight or too loose? Okay, so if your pelvic floor is too loose, you're incontinent. Fecal or bladder. If your pelvic floor is too tight, you cannot start your urine stream, that you sit there 5, 10, or stand there 5, 10, 15, 20, 30 seconds before you can relax enough to let urine out. So it's hard to pee, it's hard to have a bowel movement, and it's hard to have sex, because if your muscles are tight, it's hard to let a penis in your vagina. Julia says, when the neurologist saw me for the first time, he asked, how have you been able to manage this level of pain so far without proper medication? And it'd be fascinating to hear how you answered that question, Julia. Through stubborn perseverance and agony, that's how you did it, but you did it. And you need to pat yourself on the back for that. Jennifer says, my daughter has had IC and endo since the age of 18, needs a doctor in the Arlington, Virginia area. Most MDs have poo-hooed her. So again, Jennifer, I mean, this book, I think would be really reasonable for you to get, because I think that it would give you a little bit more insight into how to controlling that. But you might need to go to a national specialist. Robert Eckenberg practices in Pennsylvania. He's probably the top pelvic pain doctor in the United States. Getting that endometriosis under control is a must. So I encourage you to go over and join the Endometriosis Association. They have an absolutely fabulous website. One of the things that the Endometriosis Association recommends, and I recommend this too for everybody, IC, IBS, endo, is you got to get the chemicals out of your homes. You have to clean out all the toxic chemicals out of your homes. Why? Because we have proof that some toxic chemicals trigger endometriosis and make it worse because they have estrogen mimicking effects. And again, she talks about that too a little bit in the book. And so they've got really good tips on how to eliminate chemicals from your home. We don't want you to use Febreze, fabric softeners, scented candles, especially scented candles from China where you don't know what's in them. Those have been, in many cases, proven to release carcinogenic smoke. And so avoiding any harsh chemicals which could worsen her endo is important. They might be doing things that would help control estrogen production in her body. And so the Endometriosis Association will set you straight, my dear. They'll give you some really, really good ideas and a good treatment pathway. Julia, the answer is breathe. Good for you, Julia. So Maddie, if yours too tight, you know, then if the original doctor who did, oh wait, hold on. I don't know. I'm sorry. I don't remember if you were the one who had the suspension surgery. Guys, have a pelvic floor assessment, work with your pelvic floor physical therapist. And seriously, if you have not done it yet, for God's sake, would you please invest in this book, Ending Male Pelvic Pain or Ending Female Pelvic Pain. This book will teach you more in 5 minutes than you will learn anywhere on the internet. Anywhere. And it is chock full of things that you can do to make it, to stretch, for example, if you look at this, they call it the prayer squat. Generally, if your pelvic floor muscles are feeling tight, if you go down into that squatting procedure, that puts the muscles in the correct position and correct consistency. That's kind of a good way to kind of get your muscles to stop spasming. But this book is incredible. Absolutely incredible. You know, if you have got tight pelvic floor muscles, you cannot figure it out on your own. You have to work with a physical therapist at least once to identify the correct muscle group. So, and I apologize if this is an offensive position, but I need you to look at this. So this gives you an idea of the different location of muscles, right? You got lower muscles, you got middle muscles, you got higher muscles. And in your pelvis, well, I don't want to flip you off there. Sorry about that. You've got you've got muscle. If you were to stick this finger in your vagina or in your rectum, you would have shallow muscles, middle muscles, and deeper muscles. And you need a pelvic floor assessment at least once to identify the muscle that's messed up. So for me, after my hysterectomy, it was my levator muscle. And it was giving me a lot of rectal pain for months and months after that surgery. Now that that's improved, I'm back to my original pelvic floor problem, which is my piriformis muscle. So if you can at least once have a pelvic floor physical assessment, and if you can't afford pelvic floor physical therapy, that's fine. You can use a book like this. The physical therapist will give you some exercises to do and go back once a year or once or twice a year to just see if what you're doing is good. I will tell you there are a lot of really good videos on YouTube. So you can search for, like I searched for piriformis rehabilitation, and that brought me to a really, really good video that I use. I use the Sequence Wiz. That's a brand name, Sequence Wiz, W-I-Z, yoga on YouTube. I should be doing it once a week at a minimum. Allison, you've been getting extreme pain before you pee. It feels like it's in my urethra. It also makes it hard to start my flow. So your urethras were approximately the size of your middle finger, and it's narrow. If you feel like you're peeing through a needle, that means that your pelvic floor muscles are probably squeezing your urethra. I would definitely go to your doctor and tell them about that and see if they can find anything else. We don't want you to get into urinary retention. So anytime you get to the point where you can't start your flow, you need to get back to your doctor. Let's make sure nothing else is going on. And then you're really going to be talking with your doctor about what would be making it difficult for me to pee. Is it my muscles? Is there something else going on? See, I think you need to talk to your doctor about that, okay? So Lori says, if the scope of my bladder showed no IC, then how come I'm still having symptoms of IC? My urologist said that sometimes they have to do a hydro. So Lori, that's when we go to the subtypes. So I also have a completely normal bladder. It shows no signs of bladder damage, but I definitely have IC. But I'm a different subtype. I don't have IC subtype 2, bladder wall driven, or IC subtype 1, Hunter's lesions. I've got IC subtype 3, pelvic floor, and subtype 5, which neither of which cause bladder wall damage. Okay, and so tight pelvic floor muscles can cause frequency urgency pressure pain. So can central sensitization. If you're IC subtype 5 where it's inherited, yeah, you're going to have a more sensitive bladder, which would explain your symptoms. Oh, Laura, that book is $55 on Amazon? Really? You know what? I honestly didn't look. Let me check their website, because on the book itself, it says I think it's $35. Let's see. Let me look at that. It's $19.99 on their website, guys. $19.99 on whenithurts.com, 19.99. So don't get it on Amazon, get it on their website, okay? Maddie, you're in physical therapy. It's hard for her to even work on you. Yeah, sometimes your muscles are really screwed up and they're super tight, and you just have to be slow and steady. You can't, one of the mistakes that patients make when you go to a physical therapist, and especially during that pelvic floor assessment, when you have that first appointment, they're looking for your pain. Most of it's an external exam. They look at your legs, they look at your hips, they look at your butt, they look at your belly. They're looking for pain tension patterns. They're going to measure the length of your leg, see if you've got one leg shorter than the other, right? And then they're going to do an internal exam, and they're going to gently touch muscles. And if they can touch the muscle and cause the pain, that is an incredible victory. That is exactly what we want to see. It's like, oh my God, you found it. Hallelujah. We know where it is. We have hands. It has been found. A lot of times that scares patients, though, and they go, I don't want to go if it's going to hurt. And so they never go back. And that's a great tragedy, because when you go back to physical therapy, they're not going to be pushing hard. They're going to be gentle. They're going to be lengthening muscle. They're going to be rubbing muscles to try to get them. Like when I have my levator, when I had my levator physical therapy, basically her finger was going like this internally, just gently trying to lengthen that muscle. And so don't be afraid after that first appointment. And if you do physical therapy and it hurts, you need to tell her that it hurts. You need to tell her that she needs to back off. But maybe you also need a muscle relaxant, like the vaginal Valium suppository or baclofen or Flexeril, to try to get those muscles out of spasm. But you have to keep with the muscle work. Do muscle work. And medication that can impact muscles, like a muscle relaxant. So then this is a perfect example. Julia says, pelvic floor physical therapy made a huge difference in my case. I was barely penetrable. There was almost no difference between contraction and relaxation. You know, and the thing is, guys, is pelvic floor injuries can happen in childhood. They can happen if you were the dancer, like I was telling you earlier, the dancers who did ballet from the age of 5 to 20 who ended up with terrible pelvic floor dysfunction. Pelvic floor dysfunction is sometimes rooted historically in old injury or in doing things you shouldn't be doing, like sitting for long periods of time. Or it can also happen if you've gained a lot of weight and you're forcing your body to carry a lot of weight on your pelvic floor. But just know that when you work with muscles, miracles happen. As Dr. Payne said in his proposed 5 subtypes, he said, if there's one subtype that's curable, it's pelvic floor. When you do it right, pelvic floor muscles respond beautifully to pelvic floor physical therapy. Julia, thank you so much for sharing your story. That is absolutely incredible. Now, I hope that you found this helpful today. I really, really do. If you like our live support group meetings and or if you like our website and all the other stuff that we do, I will tell you that we are the largest support group in the world. Everybody participates for free. There's no paywall. So how do we support all of this? Is through memberships where you can get our magazine, The IC Optimist. Most of this information does not appear on our website for at least 6 months, sometimes a year. It goes to our members first. And these are really comprehensive stories about IC. So you can come over to our website, and I hope you'll consider becoming a member of the IC Network because it's just $25 a year if you're willing to read it online, or it's $50 a year if you want us to mail it to you. And you'll also get lots more perks with this. For $25 a year, you'll get 8 total issues, 4 back issues and 4 future issues. And then for the next one, you get 12 issues, and the one after that, you get 6 years worth of issues. And so there's lots of wonderful things that go along with this. We will be redoing our IC diet, and I hope to have it released by the end of the year. And so all of our members will get all that for free as part of their membership. And I'm also working now on a new online course for IC that will be a series of videos, about 50 videos put together in a course, like little 3 to 5 minute videos to kind of work you through a lot of the things that we've talked about in these. And again, our members will have free access to those. All right. So please support us if you can. That would be very appreciated. However, far more importantly, the single most important thing that I say in every single meeting, the single most important thing I want you to remember from this meeting is that this is not your fault. You have done absolutely nothing wrong. There is no shame. There is no blame. You are a wonderful man. You are a wonderful woman. You are no different than someone who is hit by a car. You deserve the love and attention of your family. And yet we're so good at hiding it. We're so good at thinking that we're damaged goods. And we get stuck in this depression where we start thinking that we're unlovable, that our partner should leave us, that we're terrible at this, terrible at that. I know that because I did that too. And it wasn't until the family research came out and the genetic research came out that I finally realized that it was never my fault in the first place. That I'm sensitive, and it's a gift because I'm going to smell the fire first. The world needs more sensitive people. I don't want you to carry any shame or any blame. I want you to be able to look in the mirror at the end of the day and feel proud of yourself. You have never worked hard as you're working right now to get through this because some of you are in agony right now, and it's a minute by minute, hour by hour thing. And I want you to ask for the help when you need it. You deserve the help. I mean, listen, if your partner was diagnosed with cancer, you'd be there holding their hands. You deserve exactly the same thing. However, I need you not to be patient and passive. I need you to be proactive and a responsible participant in your medical care. We call that being a respondent. Instead of being a patient, we want you to be a respondent. I want you to be able to walk in any doctor's meeting and be prepared to kick butt if anybody tells you that this is all in your head and that you need therapy. So how do you do that? every day, I need you to do 3 things. Little things. Every day for 15 minutes, I want you to do something to calm and soothe your soul. I don't care what it is. You can hug a redwood, you can go to church, you can listen to Joel Osteen, you could read poetry, whatever makes you feel good. I want 15 minutes dedicated to making you feel better because you deserve it. Let's find some peace in here. The second thing I want you to do is for 15 minutes a day, I want you to do something for your bladder or your pelvis. Whether it is following the diet, whether it is getting out and walking, whether it is going to the gym or doing your yoga, do something for your body. Meditating, do something that will lift your body in the long run. And then lastly, I need you to build your noggin here. I need you to improve your knowledge of IC. You know, nobody could ever tell me that my IC is all in my head. I mean, I am loaded for bear. I double dog dare them to try that with me. I will throw research after research after research at them and defeat that argument. I want you to be able to do the same thing, and you can, but you can't do it all at once. You gotta learn your knowledge. My knowledge right now is based on 25 years of reading about IC, including 90 minutes reading this book last night on a Saturday night. It would have been nice to be out, but no, I read this book. It was really good. So for 15 minutes a day, I need you to read about something to improve your knowledge. And so come to our website, just read one article. You don't have to read the whole website. Just read an article, read something. Let's build your knowledge here. And of course, if you ever have any questions about IC, you're always welcome to give us a phone call. You're welcome to send me an email. I will tell you, I get hundreds of emails a day. It is much harder for me to respond to you by email. However, my email address is icnetwork@mac.com. But the best way to get a hold of me really is by phone. 1-800-928-7496. We also do wellness coaching. And so if you just have a couple of questions, just call. It's free, not a problem. Happy to take any question you have. But if you want to spend a lot of time talking about your history and you want to kind of work on creating a plan for your next doctor's visit or preparing for tests or something like that, you know, think about signing up for a wellness coaching session, because then you go to the top of the list because wellness coaching patients come first. And I'm more than happy to help you that way too. Alrighty. So let's see if there's any last questions. Jennifer writes, I tell my daughter, just because people can see your pain, cannot see your pain, don't let it get you down. You still have to live life each day as much as you can. Your diet has helped her so much. It took her 5 years, but got through college. You've helped me as a mother to support her. I will get that. But girl, Jennifer, seriously, you just totally made my day. Thank you so much for saying that. That's really my goal here. All righty. Okay, my friends, it is Sunday. It is 3 o'clock here on the West Coast. That means I want you to get yourself out of your house, get outside, enjoy the beautiful weather. If you're on the East Coast, fix a bladder-friendly food, get a book, hang out with your family, and I hope that you have a wonderful evening tonight. I wish you well, my friends. See you later. Any last questions on YouTube? Facebook is shut down. I always come back to YouTube for an extra minute if there's anything else here. Alrighty, my friends. I will see you well. I wish you well.